Hello friends, I am Dr. Poonam Kela, working as Assistant Professor at PES Modern College of Pharmacy, Nigdi. So today I am going to conduct a lecture on angina pectoris. So what is angina? It is severe chest pain due to imbalance between demand and supply of oxygen. It is classified into three types. First one is stable, second is unstable, and third one is variant angina. In stable, the features is occurring during emotional stress and heavy exercise, typically common angina, easily predictable, caused due to atherosclerosis. Then the unstable angina is more uncommon and atypical, most of the times occurs at rest and very rare during exercise. It is totally unpredictable, caused due to atherosclerosis and blood clot formation. Then last one is variant. It is also called as prinzmetal angina, occurs mostly at night and early morning, caused due to vasospasm, that is vasoconstriction. In this picture, I have shown what exactly happen in all the types of angina. You can see that when the coronary artery is normal, the lumen of artery is more, but when there is stable angina, then atherosclerotic plaque formation is occur. In unstable angina, there is atherosclerosis plaque with blood clot is happen. Then last one is variant angina. In that, coronary spasm is occur. Now we will move toward the epidemiology. Angina due to ischemic heart disease affect approximately 112 million people. The prevalence of angina increases sharply with the age in both sexes. In these figures, you can observe that as the age increases, the risk of angina get also increases. Now, the signs and symptoms. The most characteristic feature of angina is chest pain, tightness, aching, fullness or burning of chest, epigastrium or left forearm, then breathlessness, nausea, fatigue, dizziness, sweating and anxiety. The characteristics of angina pectoris: the onset develop quickly and slowly, location slightly to the left of sternum, it radiates toward the left shoulder and upper arm, left arm to elbow, wrist, fourth and fifth finger, radiate to right shoulder, neck, jaw and epigastric region. The duration of pain is less than 5 minutes. Sensation: light quizzing, burning, pressing and choking, aching, heartburn is observed. The severity is mild to moderate. Now the etiological factors include coronary vessel disorders, in that atherosclerosis and arterial spasm. Circulating disorders include hypotension and aortic stenosis. Blood disorders, in that anemia and polycythemia leads to decreased oxygen supply. Then next is oxygen demand increases, which also lead to angina pectoris, which includes increased cardiac output, increased myocardial need of oxygen. Then next is pathophysiology. The angina pectoris occurs when the oxygen need of the heart are not met. The myocardial oxygen demand increase when there is an increase in heart rate, myocardial contractibility, peripheral resistance, ventricular volume and ejection time. So first, what is happen in the angina pectoris? That is, there is increased production of lactic acidosis. Why this is happen? When due to the angina, the narrowing of coronary artery takes place, which ultimately leads to insufficient blood flow. That leads to myocardial oxygen demand exceeds supply. Anaerobic metabolism with lactic acid accumulation happens, which leads to myocardial nerve fiber irritation and which produce pain message transmitted to cardiac nerve and upper posterior nerve root. Then next is decreased ATP generation. In this slide you can see that what we have seen in the definition, it is an imbalance between oxygen demand and oxygen supply. So in the left side of slide you can see that the oxygen demand is increased due to ventricular pressure or ventricular volume, which increases contractibility of heart rate, wall tension, which ultimately lead to oxygen demand. And in right side you can see that the duration of diastole, aortic diastolic pressure and coronary vascular resistance leads to the difference of arteriovenous oxygen pressure and coronary blood flow, which leads to oxygen supply. Now the next is that I have already told you the atherosclerotic plaque formation, arterial spasm and thrombus ultimately leads to the angina pectoris. So in this slide you can see that the atherosclerosis plaque is gradual obstruction of the artery. Arterial spasm is a sudden reversible obstruction of the artery, but atherosclerosis plus plaque splits plus thrombus is sudden and non-reversible obstruction of the artery. The three factors ultimately leads to the ischemia, which is nothing but the hypoxia, which leads to the reduced oxygen demand, that is formation of angina pectoris. When the thrombus get splitted, that is thrombolysis is happen, then unstable angina is occur. Then next is risk factor, in that obesity, age, social habit, stress, hypertension, diabetes, renal dysfunction. These all the factors ultimately leads to the angina pectoris, because this decreases the demand. This decreases the supply of oxygen and increases the demand of oxygen to the heart. Then next is complications, in that heart failure, acute renal failure, myocardial infarction, cardiac arrest, atrioventricular block, severe arrhythmias. The diagnosis include physical examination. So in physical examination, the primary diagnosis is based upon description of symptoms by the patient. In that, what kind of pain is occur, the duration of pain, its association with other factor like exertion, meal and weather. Then next is ECG. The resting ECG, it is helpful to find previous myocardial infarction and is little useful in that the T wave flattening is occasionally seen. The next ECG is exercise ECG. A standard formal exercise tolerance test is performed to increase workload on heart, followed by recording of the ECG during exercise stress. The changes in ST segment, abnormal pumping motion of wall of left ventricle are common findings. Then echocardiogram, chest X-ray, coronary angiography. It is generally used when other non-invasive tests have failed to diagnose the angina pectoris, and angiography reveals the severity of the disease and gives a view regarding need of coronary angioplasty. Then cardiac MRI, coronary CT scan, blood test. Here the acute chest pain leads to find out the reason. For that we have to do ECG. If the ECG shows ST elevation, then it is acute MI, but no ST elevation, then we have to do troponin test. If the test is negative, then there may be two possibility. Test is negative or test is positive. If the test is positive, then it is unstable angina or acute myocardial infarction. The test is negative, then if the chest pain is in less than 6 hours or more than 6 hours, if the chest pain is less than 6 hours, then we have to again go for troponin test. Then there is two possibility, test is negative or test is positive. The negative test indicate low risk of cardiac diseases, and positive test indicate unstable angina or acute myocardial infarction. Then next is a treatment. In the non-pharmacological therapy, moderate fat restriction in diet, daily weight measurement, modest physical activity, avoid medication that can exaggerate heart failure. Then proper dietary plan, avoid social habits is useful. Then pharmacological therapy includes nitrates that dilates the blood vessels, which ultimately decreases the angina. It is of two types, short acting and long acting. The short acting includes glyceryl trinitrate in the dose of 5 to 15 mg TDS oral, then 5.5 mg sublingually. Then long acting includes isosorbate dinitrate and isosorbate mononitrate in given doses. Calcium channel blockers. There are three categories: phenylalkylamide, benzothiazepine and dihydropyridine. These are also given in the given doses. Then beta adrenergic blockers. Beta blockers, this drug reduces myocardial oxygen demand by reducing the heart rate, blood pressure and myocardial contractility. The examples are bisoprolol and propranolol. These are given in the following doses. Then potassium channel openers. Example are nicorandil 5 to 20 mg BD. Then next is a surgical management. In that, first one is percutaneous coronary intervention. It consists of grafting veins or arteries from the aorta to coronary artery to bypass the stenosis. The arteries or veins are usually taken from the region beneath the sternum. Then next is coronary angioplasty. It is an effective symptomatic treatment for chronic stable angina, a single or double vessel diseases. The technique involved is the insertion of the guide wire through peripheral artery to coronary stenosis, followed by inflation of balloon to remove the stenosis. The inflation and deflation may be repeated several times as per the requirement. The guidelines which is useful while prescribing drug to the anginal patient with concomitant diseases. If the patient have no concomitant diseases, then we can prefer long acting nitrates, beta blockers and calcium channel blockers. If the patient have concomitant disease such as MI, then we prefer long acting nitrates and beta blockers. Then if the patient have asthma with angina, then we can go with the long acting nitrates and CCBs. Then HTN with angina, we can go for long acting nitrates and beta blockers or calcium channel blockers. If the patient have angina with DM, then we can go for the long acting nitrates and calcium channel blockers. If the patient have angina pectoris with chronic renal diseases, then we can use long acting nitrates, CCB and beta blockers. So in this diagram, I have mentioned how to follow the guidelines or how to advise the medicine to the patient. So if the patient have heart rate more than 60 beats per minute, then we have to measure the BP. If the systolic BP is more than or equal to 120, then we can use beta blockers or calcium channel blockers. If patient doesn't have any benefits of this treatment, then we can go for the dihydropyridine or ranolazine or ivabradine. If the patient doesn't have relief from this medication, then we can go with the nitrates, that is long acting nitrates and nicorandil. If the heartbeat is more than 60 beats per minute but the systolic blood pressure is less than 120, then we can go with the ranolazine or ivabradine. If there is no relief from this medicine, then we can go with the trimetazidine. Then next is, if the heartbeat is less than or equal to 60 beats per minute, then we have to again check the blood pressure of the patient. If the systolic blood pressure is more than 120, then we have to go with the DHP. What is DHP? That is dihydropyridine. If there is no relief, then we can go with the ranolazine. Then next is long acting nitrites or nicorandil or trimetazidine. Then next is, if the systolic blood pressure is less than 120, then we can go with the ranolazine. There is no relief, then we can add trimetazidine. Then patient counseling includes follow the proper diet, do healthy diet, then proper exercise, avoid smoking, avoid alcohol. Patient need to understand the treatment option. Thank you so much for patient listening.